Let's discuss gingival grafting with Periderm. Dr. Danny Melker has been a speaker at my teaching center in Dallas when that was going on several times, and he is the guy for using Periderm and gingival grafting, and he taught us this technique. So we've got basically no attached gingiva right here, and then we've grafted with Periderm here. This is an article in the library of dentistrymasterclasses.com by P.D. Miller, classifying gingival recession. This is a class 1 marginal tissue recession which does not extend to the mucogingival junction, meaning it's only in the non-keratinized unattached gingiva. See, here's the mucogingival junction right here. This is attached gingiva, this is unattached. So a class 1 means it does not extend to the keratinized attached gingiva. There's no periodontal bone loss in the interdental area. So you can expect 100% coverage of this, of the tooth up to the level of bone in the interdental area. A class 2 marginal tissue recession which extends to or beyond the mucogingival junction. See, here's the attached gingiva, and this extends to or past that. There's no periodontal loss in the interdental area, meaning the bone levels are symmetrical between all these teeth. So you can expect coverage. In other words, you've got bone up to here, so you can expect the surface of the tooth to be completely covered. Class 3, the marginal tissue recession which extends to or beyond the mucogingival junction. There's bone or soft tissue loss in the interdental area, in these areas, or malpositioning of the teeth preventing 100% root coverage. So in those cases, all you're going to get is some attached gingiva. You're not going to get root coverage up to the ideal position. And this is so good to know. This article is one of the most important articles in dentistrymasterclasses.com because you know what to tell the patient to expect. Sometimes I tell the patient I expect to get coverage so aesthetically the root is covered. Other times I tell them we're not going to get root coverage, we're just going to get attached gingiva, or we're going to get keratinized gingiva. So what is the benefit of that? Well, the attached gingiva, the keratinized gingiva is like a hard rubber band around the tooth to prevent bacteria from getting down the root of the tooth. If you've only got non-keratinized unattached gingiva, this flimsy stuff around the tooth, then bacteria can shoot down, and calculus and plaque and all that can go down the root of the tooth, causing bone loss and eventually lose the tooth. So you want attached gingiva around the neck of the tooth. How much non-keratinized, non-attached gingiva is okay? I mean, you want at least a couple of millimeters of attached gingiva, keratinized gingiva, on the facial surface of a tooth to have that hard rubber band to keep the bacteria and the calculus and the plaque from getting down the root of the tooth. So this class 3, you're not even thinking about coverage. You're going to get some coverage, but if the bone level, if the interdental bone is down to here, you're not going to cover up to here. You've got to have the interdental bone to get root coverage past a point of soft tissue past a point. In class 4, marginal tissue recession which extends to or beyond the mucogingival junction. Here's the mucogingival junction. Severe bone or soft tissue loss in the interdental area and or malpositioning of the teeth. So we're not expecting any root coverage because we don't have any bone. You've got to have bone to get root coverage. You have to have bone up to the level that you want the root coverage. You can't just put soft tissue out here in space. If you had bone up to here, you could get root coverage up to here. But if the bone's down here, you're not going to get any coronal placement of the soft tissue. You're going to get attached gingiva if there is none there. So this is very important to know before you start grafting sites, so the patient understands what they can expect. See, so this is how you determine where the attached gingiva is. You can't move attached gingiva. You can only move unattached gingiva. So see how this is folding? There's no attached gingiva around those teeth. See, this folds all the way. This ends about right here, so we've got a little bit around that tooth, but we don't have any attached gingiva around the lower anterior teeth. This patient had orthodontic treatment, and I think the lower teeth were moved facially, and sometimes that possibly could affect the attached gingiva. This tissue is very thin, very friable. So I'm going to make my incision with this 15 barred Parker, really thin tissue. We're doing this not for root coverage. This is that key point. We're not doing it for root coverage. We're doing it because there's no attached gingiva. So we're doing it to protect the roots of the teeth, to get that hard rubber band around the roots of the teeth so the bacteria can't go down the roots of the teeth. This is number 12 barred Parker. And you're not removing the papilla. You're going to suture into the papilla. So you can use, you don't have to use a full thickness flap. It's actually ideal if it's a split thickness flap, but if the tissue's this thin, that's not an option because you can't, it's so thin you can't separate it into a split thickness, so you're going to reflect a full thickness flap. This will cut in to the papilla this way, leaving the papilla, but you're going to remove the facial half. Just be very careful. It's like working with toilet paper. It's so thin, so keep no big movements. Keep the periosteal elevator on the bone and just peel it away. It's hard to reflect this tissue. See, it's too thin for a split thickness flap. So just very carefully reflect the flap. You don't want to perforate the flap if you can help it. That compromises the result. So what we're trying to do is just reflect the flap so we can place the periderm under the flap. So you don't want just a little barely reflected flap. You want to reflect fairly significant, down to about here. Because it's important in the end that the periderm is covered by the flap. You want the periderm completely covered by the flap. Now I'm using the larger end of the periodontal elevator. Just slowly reflecting that tissue. I'm not worried about getting all the tissue off the alveolar process. You can see the bone level is pretty good here. So we have good interdental bone, but we're not trying to increase the height of the gingiva. We're just wanting to add attached gingiva. And periderm histologically doesn't look like attached gingiva, but it acts like attached gingiva. There's some histology you can read about in some articles I'm going to show you here in a moment that talk about that, but this is how they want you to position it. With this little cut in the upper left-hand coronal, so the dermal side is facing out. Now, some say it doesn't really matter which way you place it, but if you can, place this side out. The nice thing about periderm is it adapts to the teeth and to the bone once it's wet. And you need to soak it a little while. Read the directions, and you soak it before you place it. and it adapts real nicely. It's not like a stiff shirt or a starched shirt. So you want it down in the bottom of the flap far enough that the flap doesn't lift it up. So you have to reflect far enough that the flap will go over it easily and not be strained. I'm reflecting a little bit more. Then this is 5-O-Proline. You want a deep bite in the flap, and many times you'll come through, actually go through the periderm, because you want to hold it tight against the teeth. So you go through the flap here and then go through the periderm, and then take the back end of your needle and push that through this interproximal area. When you suture, go 3 wraps in the clockwise direction, 1 wrap, then pull that tight, and if you do 3, it'll stay. If you do 2, it'll loosen. So do 3 wraps in the clockwise direction, pull it snug, then 1 wrap counterclockwise, pull that snug, and then 1 more wrap in the clockwise direction and pull that snug, and you've got a good tight knot if you do that. So we're going deep into the tissue, and then we're going through the periderm on the way through, and then take the back end of your needle and go through the interproximal area. See there, I'm going through the periderm to lock it in, and then come back with the back end of your needle so you can tie the knot on the facial side. Many times in surgery, suturing takes longer than the surgery itself. So 3, 1, 1. So there we have that. This is after a week of healing. Now you have to remove this proline after 1 week of healing. If you let it sit 2 weeks, you're going to have to anesthetize the patient because the tissue grows over the proline. It's not like gut suture that dissolves. So you've got to have them back in a week and remove the suture, or you'll have to anesthetize it to remove it because the tissue will have grown over it. This after a week of healing. This is after a year healing, and we veneered the teeth so you can see, if you try to move the tissue with an instrument, you can't move it past here. So this gingival tissue is attached, whereas preoperatively it was not. So that's the dental minute. These techniques work, and they work every time.
Don't you want to take your practice to the top tier? Subscribe to dentistrymasterclasses.com for an organized library of all the Dental Minute videos, plus many complete comprehensive cases and so many important articles that you can only find right here. New cases are added weekly, and it's only $20 a month. Subscribe today.